Okay. Good morning, everyone. It's my pleasure to introduce our speaker today, who must be around the corner. Sorry. Dr. Maurer received his medical degree from Oregon Health and Science University in 2004, then completed a pediatric residency at the University of Washington and a fellowship in pediatric hematology oncology with palliative care training at St. Jude's Children's Research Institute. He is board certified in pediatrics, pediatric hematology oncology, and hospice and palliative medicine. We were lucky to recruit Dr. Maurer to the University of Pittsburgh and UPMC Children's Hospital in 2010. Dr. Maurer rose through the ranks to professor in pediatrics in 2023. Dr. Maurer has received many awards and honors and accolades with strong themes throughout being a top educator, a caring physician, and a leader in the field of pediatric palliative care. He has made seminal contributions to his field with over 40 peer-reviewed publications and at least 14 invited talks. His formal mentee list is over 60 mentees that range from undergraduates to faculty. His informal mentee list includes everyone he touches with his time, and this includes me. Dr. Maurer is now the chief of the Division of Palliative Medicine and Supportive Care, which has been its own division since 2023, so happy second birthday. He is also a member of the Pediatric Hem-Onc Division here at the University of Pittsburgh School of Medicine and UPMC Children's Hospital, and is a gifted oncologist. Dr. Maurer is the medical director of a large palliative care and consultative service focusing on advanced care planning, decision-making support, pain and symptom management, care coordination, end-of-life care, and bereavement care for pediatric patients with life-threatening illness. He studies patient-reported outcomes and psychological interventions in children with cancer. He both teaches and designs curricula for advanced communication skills in the Vital Talk organization, which is a big national, international organization. Today, Dr. Maurer is going to speak about discovering the patient's voice using patient-reported outcomes to improve clinical research and care. Thank you, Dr. Maurer.
Tap in, tap out. Hi, everybody. How are you? Hey, good morning. Good morning. Is that okay? We're good. All right. Good morning, everybody. Thank you for coming in. I was driving in and it's such a beautiful sunrise this morning. I was like, oh, that's nice coming over the bridge. So thank you for being here. It's the last Grand Rounds of 2025. So I'm happy to be giving that one, and happy holidays to everybody. And hopefully we'll have a great 2026. Today, I'm going to talk to you about some research that I got into with a research group aimed at developing patient-reported outcomes. And a couple of things that I wanted to sort of talk about was what this meant as far as our ability to enroll children on clinical trials, not only with cancer, but to think about other chronic illnesses or whenever we're enrolling children on clinical trials. And then some unexpected things that we discovered along the way that really impacted the way that I take care of patients at bedside, that I'm hoping I can impart upon all of you to maybe consider when you're talking to patients and families about difficult things. And so the alternate title of this talk could be "What I Do When You Don't See Me in the Hospital," but I'm happy to talk to you about it today. So what we'll talk about is what are patient-reported outcomes and why are they important? I'm going to talk about how we developed a PR. I'm going to call it PROs from here on out, or pros, and how we developed a tool for that in pediatrics and what tools are available currently in pediatrics for PROs. And then what this taught me about providing care to children. And after 15 years as an attending, I have nothing to disclose still, and doubt I ever will, but I'll keep aspiring to it. So let's talk about patient-reported outcomes first. And in order to understand that, I want to talk about really how things happen in the traditional sense. And anyone who runs a clinical trial or reports for a clinical trial is probably familiar with the common terminology criteria for adverse events, or the CTCAE. And up here on the screen is an example of a CTCAE. And this is the way in which we grade adverse events that happen during the course of a clinical trial. And so things to know about CTCAE is that this is something that's required for all National Cancer Institute trials. The FDA requires it for approval of any drugs that it approves. And there's over 700 items, and some of them are very specific, like a hospitalization or a broken arm, and very easy to grade. And some of them are subjective, like the ones that I've put up here, like abdominal distension or abdominal pain. The trick here is that the people who are grading these things are often not in the room with the patient when the patient is reporting these adverse events. And researchers are not usually trained in exactly how to do this. And there is a bevy of literature that demonstrates that clinicians are notorious for underreporting symptoms. And I'll give you a little story. About 10, 11, 12 years ago, there was a sudden departure from the Division of Hematology Oncology, and I suddenly found myself as the PI of a study using vaccines to treat incurable brain tumors. And I was sitting in a room with our wonderful research coordinator, Sharon DeBridge, and we were going over patient charts, and we were doing CTCAE grading. First of all, I had never been trained on how to do that. Second of all, I hadn't actually seen the patient. I was relying on the documentation that the provider that was in the room with them had seen. We were going through the note, and I was like, yeah, that looks like it's a grade 2. And that's how the grading for that worked. I think you can all admit that that's probably a subpar way of grading things, right? PRO data cuts through all of that, cuts out the middleman, and the person that's directly reporting the symptom is the patient. And so for that reason, the FDA came along in 2009 and said, we're going to advise that any drug seeking approval from the FDA uses PRO data. And the National Cancer Institute followed suit and really paved the way, meaning they paid for it, to develop PRO tools for clinical trials starting in adults. And the idea was to have PROs be submitted by the patient and then translated by a measurement system into a CTCAE grade. And so what happened after that is a good guy named Bryce Reeve and Bausch came along, and they developed something called Pro CTCAE, and it was for adults, and it was developed in cancer. And basically what it does is it links a patient report to a CTCAE grading that could then be reported to the FDA and the NCI for clinical trial safety and also for drug approval. So Pro CTCAE is now widespread in cancer clinical trials in adults, and it's starting to be implemented in adult cancer centers for treatments for there. And basically what this is it's a library of symptoms that clinicians or researchers can choose from, and they can literally just pick it off the shelf. You think your drug is going to cause nausea and vomiting, grab nausea, grab vomiting. You think there might be anxiety or something that's caused by a drug, you grab anxiety, you grab depression, you grab loneliness. You can literally pick them off the shelf, and they measure things more than just the presence of the symptom. They talk about the frequency, the severity, and the interference of that, and then it converts that into a grade. So much more detailed and coming directly from the patient. And there's some cool things that have come from this. At Memorial Sloan Kettering, Bausch did a study looking at implementation of PROs in clinical care for adults with solid tumors. So there were over 400 adults with solid tumors who were administered PROs during a treatment visit, either for an infusion or a chemotherapy treatment. And basically what happened is they would fill out this form, and if they noted a symptom, it would alert a nurse coordinator who would then contact the patient and try to address the symptom. There's an interesting caveat to the study in that computer literate patients who were more comfortable with computers, they were in this first set of columns. They would fill things out by email links and things like that. Less computer savvy patients had an actual human being who would come and sit down and go over this with them. And what you can see is that when PROs were used in clinical care, there was an improved health-related quality of life scores for those patients. Fewer patients reported a decline in their health-related quality of life. There were fewer emergency department visits, fewer hospitalizations, a longer duration of palliative chemotherapy, and there was a longer quality-adjusted survival, meaning days that the patient survived where they had good quality of life. And if you looked at the second bar is the group of patients that were less computer savvy, the result was magnified if there was an actual human being administering the PRO tool. So kind of cool that we can improve clinical care by using this. So that got Bryce Reeve thinking, and he gathered a bunch of pediatric palliative oncologists, and we're a small group, so we all called each other, and we were like super excited about this. And we started asking ourselves some questions. What about pediatrics? Can we develop a tool like this for children to self-report? So we asked ourselves a couple questions first. One, do we think children with cancer have a high symptom burden? Are we good at addressing these symptoms? Who's reporting those symptoms? And are we doing everything we can to help reduce suffering in children with cancer? We were focused on cancer. And so we already know the answers to a couple of these questions. And to demonstrate, I'm going to show you some data from one of the landmark studies that really launched pediatric palliative care into the public consciousness. 25 years ago, Joanne Wolfe and her colleagues published this study in the New England Journal of Medicine that looked at parent-reported symptoms in the last 30 days of a child's life with cancer. And what she found is that there's a lot of symptomology that happens during that time. In this top bar, you can see the dark black bars are the prevalence of symptoms that parents reported in the last 30 days of their child's life. And the slight gray bar next to it is parents who noted that their child suffered. So the parents felt their child suffered from that. And you can see there's a lot of symptoms and there's a lot of suffering. Perhaps more discouraging is the box below it, which shows in the light gray box the number of times that a pediatric oncologist attempted to address the symptom. So the parent said, my pediatric oncologist addressed this symptom, and the box next to it is how often they thought that intervention was successful. Not very good. What came of this study and others like it, and Joanne Wolfe we owe a lot to, as well as the other founding mothers and fathers of pediatric palliative care, is the year after this study was published, the Institute of Medicine declared a national emergency in the care of children at end of life. That spawned the field of pediatric palliative care. And by 2008, we had ABMS certifying us as our own specialty. And by 2011, we opened our first fellowship training program. So things happened really fast after all of this happened. So the bottom line is this: we know that children with cancer suffer a great deal. Prior to the widespread integration of pediatric palliative care, there was a lot of untreated suffering, and pediatric oncologists, and I'm one of them, so I feel like I can say this, we're pretty abysmal at managing these symptoms. And it also proves the point, and I still hear this today, and it always gets me a little bit, when pediatric oncologists will say things like, I am by nature, by default, by the fact that a fifth of my patients die, good at palliative care. And this data shows that pediatric oncologists are not really good at palliative care, and we know that. So that's why we need subspecialty palliative care. The other question we ask is, who are we listening to? And children are kind of used to not being listened to. We make a lot of assumptions about what children can and cannot think about. We assume that the conversation about symptoms or about death or about complications in their therapy will be difficult for them or even harmful for them. We assume that children won't have anything to offer. We assume that they won't be reliable reporters. We think that it's often too hard to figure out which age a child could reliably report things to us. These were all obstacles that we faced when we were trying to develop this tool. And people who were like, well, you can't have a 7-year-old self-report their symptoms. It won't be reliable. And we just make a lot of assumptions. And in pediatrics, we think about this rule of sevens, and many of you are probably familiar with this, where we say, from 0 to 7, we don't think a child can really meaningfully participate in their care. From 7 to 14, well, it depends on their development, and 14 above, we should make an an assumption that they can. But even that rule is crude, and it makes a lot of assumptions about the ability of children. And Myra Bluebong-Longer, in her seminal work in the 1970s, demonstrated that children as young as 3 can understand the concept of death, the permanence of death, and how that might lead to grieving. And they can grieve. And so we know that children are capable at a very young age of doing very complicated things. And we believed, as a research team, we believed that they could self-report. And then we asked ourselves, are parents in the same boat? Are we listening to parents? We might not be. So there are PRO tools in pediatrics that existed before we even started this. And so one that you guys might be familiar with is called PROMISE. And that's a PRO tool that is developed for patients to self-report, and it's developed for clinical use. And I'll say that I was actually heartened a couple of years ago when I took my kid in for her well-child visit at her pediatrician, and I was handed a parent PROMISE assessment tool for anxiety and depression. And I was like, this is really cool. I did make her fill it out, but that's fine. But it is finding its way into clinical practice. There's also the Memorial Symptom Assessment Scale and the Lansky Play Performance Scale, which is a scale that I'll talk a little bit more about later. And then now we have developed PEDPRO CTCAE. And so how did we do it? Well, we did it in 3 different phases. And so the first phase was called a concept elicitation phase. And we conducted qualitative interviews of 96 adolescents and young adults with cancer from 7 different sites across North America. And we wanted to know what symptoms should we even try and put in this library. And the most common symptoms that we reported, that children reported, were fatigue, pain, nausea, vomiting, weakness, pain. And we decided that there were 15 symptoms that occurred enough that we called them 15 core symptoms. And they span from pain, vomiting, things that I've just mentioned, and then into the emotional realm of loneliness, fear, anxiety, depression. And we called those our 15 core symptoms. But there are 62 different symptoms that we decided needed to be put in the library. Symptoms were pretty prevalent in this group. 40% of them noticed that they had a change in their body within the last week, and that a third of those changes were unexpected by the child. The other thing we found was that emotional symptoms, and I don't think this will surprise anybody in this room, but emotional symptoms were only reported, 90% of the emotional symptoms that we found reported were only reported after we asked about them. So only 10% were spontaneously reported by the child. And that teenagers were much more likely to mention emotional symptoms than younger children were. The second phase of this was we did cognitive interviewing of 81 children and 74 parent proxies. And the goal here was to establish whether the tool that we had developed could be reliably answered by this group. And we clarified any misconceptions and reworded things in ways that made more sense to them. And from there, we validated the tool. And so we enrolled 482 child caregiver dyads from 9 different centers across North America. They ranged in age from 7 to 18 because during our cognitive interviewing phase, it was very clear that 7-year-olds were very reliable reporters. And then we asked the patients and the parents about symptoms at 2 different time points. A time point where we thought they would have low symptomatology and a time point where we thought they would have high symptomatology, so that we could see if we could detect things even in a low symptom environment versus a high symptom environment. And so this is where the clinical oncologist really came into play on this, is we designed the trial to enroll kids with different diagnoses at different time points. So for example, a child with a solid tumor would have their time point 1 when they came in for their chemotherapy admission before they got chemo. And then the second time point would be 7 to 14 days later when we expect them to have complications from the chemotherapy. And then we polled 3 different people. So we polled the child themselves, the parent or the caregiver, and then we also polled the clinician or the APP that was taking care of the child. And they completed a bevy of questionnaires for us. And their responses were then anchored to those PRO tools that were known and validated that I just told you about. And I just want to say right now that the clinical research team that is shared by the Hem/Onc division and the palliative medicine and supportive care division is amazing. We were one of the smallest centers in the group, and regularly we were either the #1 enroller or the #2 enroller on a regular basis at our quarterly meetings. And all of that credit goes to Sharon DeBridge, who is amazing. We were getting high accolades from everybody. We actually reached our accrual goal we were doing a 2-year enrollment, and we reached our accrual goal after 1 year. And so the rest was gravy. So I was really proud of that. So I'll tell you this, I'm not a psychometrician, and I'm not going to elaborate too much on how we validated this study or the PRO tool. But those who know me well know that I love to validate people. In fact, Aidan Porter gave me a stamp that says validate because he knew how much I loved validating people. Carol's nodding her head. And so you can imagine my excitement to actually validate something scientifically. Despite that, I have to admit to you that validating a measurement system is not really my shtick, and I actually find kind of boring. But suffice it to say, the tool was deemed valid and reliable, and that was backed up by peer review and a lot of really talented psychometricians. And I'm proud to tell you that the Ped Pro CTCAE is now freely available to anyone who wants to use it for clinical research, cancer, not cancer, on the NCI website. You can access it, you can pick your symptoms, you can download the library and plug and play. It's kind of cool. I'm also proud to say that this is now part of a lot of COG phase 3 trials and also part of COG phase 1 trials that we're doing PROs. And that's a really cool thing. But a funny thing happens on the way to validating a tool. And all of this data gathering and all of this anchoring at 2 different time points means that we had a lot of data. And we had data from 3 different reporters at 2 different time points using multiple different measures, which meant that we could track symptoms by reporter and over time. And that was very interesting to me and the other palliative oncologists on the research team. And I want to talk to you about what we found there. So the first question the clinicians on the research team asked ourselves is, do clinicians, children, and parents agree on symptoms? And the answer to that is a resounding no. They don't agree. And they report very, very differently on these things. And so the first group we looked at was, what about parents versus the patient? And we used PROMIS measures to do this. And what we noticed was that in over 400 parent-child dyads, interclass correlations between things like mobility, so things you could see, were moderate at best. But subjective things like pain, like fatigue, like depression or anxiety, there was poor correlation between them. And what you can see in each instance, they're flipped here because this is mobility. The child is in blue, the parent is in yellow. And on the first panel, sorry, my arrow doesn't show up on your thing. If I do it over here, it will. Yeah, cool. That's the child, that's the parent. And so here, the child is reporting that they are more mobile than the parent is reporting them to be. And then it's flipped in all the others. The parent is reporting more pain interference, and the child is reporting significantly less. And that was true along every single measure that we looked at. And we also saw that those differences were magnified if the parent themselves reported a lower health-related quality of life for themselves, or if they were lower socioeconomic status. So parental stress was a huge factor in how they reported their child's symptoms. And I think we see that, right? We see that in the NICU. If the parent is super stressed, they're very worried. We see that on the hospitalist service. If the parent is stressed, they're very worried about what's going on with their child. Then we looked at, what about clinicians versus the patient report? And here we found the same thing. We used Ped Pro CTCAE because that was the common measure that both of them filled out. And we saw that regularly and consistently, clinicians reported fewer symptoms with lesser severity than the child reported. And anytime you see blue here, that is where the clinician reported significantly less symptomatology than the patient reported. Then I wanted to look at, what about the clinician and the caregiver or the parent? And the common scale that they filled out was the Lansky Play Performance Scale. And just to familiarize, if you're not familiar with this scale, this is meant to be a performance scale that you measure someone over time, their overall well-being. And for children, we use play as a proxy for how well they're doing overall. And there's a couple of things to note about this scale. So from 100 to 80, we consider that to be relatively normal functioning. From 70 to 50, we think of that as being having a moderate disability. And below that, we think about severe disability. So there's broad categories that we place this in. And when we compared the caregiver response to the landscape play performance scale with the clinician, we found massive asymmetry in that. And so what I'm showing you here is at time point 1, anytime you see this orange, that is an incidence where the clinician reported a higher play performance scale than the caregiver. Anytime you see green, they were in perfect agreement. And anytime you see blue, that is where the caregiver rated the play performance higher than the clinician. So you can see blue happened very rarely. Orange happened very frequently. And when you look at these asterisks here with a double asterisk, that is an incidence where the clinician ranked the play performance scale in the highest category with the parent marking severe disability. And if there's one asterisk, then they were one category off of each other. They were really, really disparate. And in 44% of the subjects, they were rated in a completely different category than the parent had rated them. And that held, I'm only showing you data at time point 1, that held true at time point 2. And so big disagreements about that. And so what does all of this mean? Well, in general, what we found is that parents tend to report a higher symptom burden for their child. Clinicians tend to report a lower symptom burden, and children found themselves right in the middle of the two. And these differences were consistent across multiple measures over multiple time points, at a time point where we thought they would have low symptoms and a time point where we thought they would have high symptoms. And so we're pretty convinced that this is a real phenomena that's going on here. And the question is, what does all of that mean? And what should I do with that? And how do I translate what I learned to the care that I'm giving at the bedside? And so I and others did a lot of soul searching, and we wanted to say, like, how could we translate this to better care at the bedside? And I think the first question that every reviewer on these papers, when we published over 20 papers from this study, is who's right? Who should we believe? And I think I spend a lot of time as a palliative medicine physician perspective taking. And whether you realize it or not, as a pediatrician or as a neonatologist or as a hospitalist, you do this too. And it's really, really important. And so I think what's happening here is a difference in perspective. And we have to say, what are these different voices really telling us? And I think what a clinician is telling us is, listen, I've been taking care of kids with cancer for the last X number of years. And in all of the kids that I've taken care of, this is where this kid fits. And I think we have to recognize that when we're doing that, we have an unconscious bias to remember the most difficult cases. And when we do that, we have to realize that we're probably comparing patients to outliers, which is why we are underreporting. The parent is often telling me, this is what my kid looks like today compared to the kid I know. And that may even be the kid that they know before they had diabetes, or before they had meningitis, or before they had cancer, or before they had a complex chronic illness. And the child is saying, this is how I feel today. This is how I feel right now. And I think that's why we're seeing this phenomena. And in my own clinical care, I think about 3 really important things. I think about facts, I think about feelings, and I think about identity when I talk to people in really difficult situations. And what this research has taught me is these concepts apply more than to just goals of care. It applies to symptom management, it applies to every aspect of the things that we're doing to take care of these patients. And I've really started asking myself a couple of really important questions. Who is reporting to me? What perspective are they thinking from? Where are they coming from? And why do they think what they are telling me is so important? And I've learned to ask this question. Can you tell me more about why this symptom is so concerning to you? And I might find a lot of really important things that I wouldn't have found if I hadn't asked the question. I've also learned to recognize that as a researcher, there's this temptation to say, well, who is right? And I think that we're missing the point if we're asking who is right. Each perspective is valuable. And if we're truly going to help patients feel better, we have to listen to their perspective. And we also have to help them listen to each other. And so as a palliative medicine physician, it's my job to help the clinician that is taking the neonatologist or the hospitalist or the oncologist that is taking care of that patient to really listen to the perspective of the parent, and for the parent to do the same thing with the clinician and the child, and managing this three-person kind of thing. Which brings me to the next lesson that I've learned from this, which is everyone, absolutely everyone, the parent, the child, the clinician, the nurse, the social worker, the psychologist, and on, everyone is affected by a serious illness in a child. And we have to take those perspectives into account. The other thing I learned is assessing symptoms. So as a palliative care physician, I have symptoms all the time, right? And I sort of like did it in the traditional way of, are you having pain? Okay. How severe is it? OPQRST, right? That's what we were all taught in medical school. And I think what this kind of taught me about was to think about things a little bit more systematically and think about, okay, is the symptom present? Yes or no? How frequent is it? And how is it interfering? And as a clinician, we all thought that interference would probably trump the other two, right? Because that's what really matters to us. And we actually played around when we were weighting the responses from the children and in scoring the Pitt Pro and having it spit out that CTCAE grade. We thought maybe we should rate interference a little bit higher than the other two. Turns out it didn't affect the scoring at all. And for simplicity, we just weighted everything equally. But I think as a clinician, reporting a symptom for a clinical trial and treating a symptom are two very different things. And I have now learned to sort of say, instead of saying like, do you have pain, and stopping there, how is your pain troubling you? And then also asking, and what do you think we should do about it? I think we should bring goal concordant care to symptom management, the same way that we bring goal concordant care to the overall advanced care planning and overarching goals of care. And so it taught me that. The other thing it taught me about is fairness in clinical trial access. And so in both adult and pediatric oncology, we use performance status as a means to determine how a patient is doing, either with their disease process or with a given therapy that we're prescribing to them. And over time, this sort of morphed into being a gatekeeper for clinical trial access. And so it is very, very common, and the oncologists in the room will understand this, for a Lansky score of 60 to be used as a cutoff for inclusion criteria in a phase 1 clinical trial. And there are even phase 3 clinical trials that use Lansky as an exclusion or inclusion criteria. However, we need to remember that Lansky and then the adult analogy, Karnofsky, Lansky, it's just coincidence that they're both skis. They're not related to each other and don't know each other. And then ECOG is the other one. We're used to using these scales, but these were actually designed to monitor performance. And the Lansky itself was only validated for parental report, which sort of shocked all of the clinical oncologists in the room, because the psychometricians in the room were like, yeah, it's meant for parent report. Because I was asking, like, why would we have the parent fill out the Lansky? And they were like, well, it's validated for parent report. And every oncologist on the study team was like, no way. Because we were very used to the Lansky being clinician report, because that's how we always used it, as a gatekeeper for these clinical trials. And so, and I came back after that meeting, I came back to Pittsburgh and I like sat down with every oncologist here and I go, did you know? And they were like, I had no idea. Right. And so the question is, does that matter? And I think the answer that we found is, yeah, it does matter. So if you look here, this is the number of incidents where the clinician reported that the child had a Lansky score of greater than 60, so eligible for clinical trial enrollment, versus the parent who was reporting saying they were not eligible for clinical trial enrollment. And that happened in 1 out of every 6 at time point 1. And at time point 2, when kids were more symptomatic, it jumped to 1/4, which I think is a problem. And I think the question is, well, is this fair? And honestly, I don't quite know how to answer that question, but I think we need to be more honest with ourselves about what we're actually asking here. And the question is, do you, as the treating clinician or the enrolling clinician on this clinical trial, think that this child is well enough to ethically and safely receive this treatment? And that is not a question that you answer on a 10 decile scale. That is a yes or no question, my friends. And so if we as clinicians need to man up And we need to say, yeah, I don't think this is safe or ethical to administer to this child. And if that is true, then we should not be offering the clinical trial to the child. It shouldn't even be an option. Don't talk about it. They're not eligible for it, right? But what we're doing instead is we're sort of hiding behind the scale and saying, well, he didn't score well on this Lansky scale, so what that means is he can't be on it. Sorry. And I think it's a cop-out. It's a total way of like kicking the can down the road to talk about what's really happening with this child. And I think we just need to leave Dr. Lansky out of it. She didn't join this fight. The last lesson that I want to share with you that I learned about this was what this taught me about talking to children about phase 1 trial enrollment. Most of you will know this, but as a reminder, phase 1 clinical trials are used only for children who have incurable cancer. And in fact, the first inclusion criteria for a phase 1 clinical trial is that all curative therapies, potentially curative therapies, have been tried or are not able to be administered to this child. Can't enroll in a phase 1 without that. The other thing is that at their core, phase 1 trials are not about curing cancer. They're about measuring dose-limiting toxicity. And so we know that less than 20% of children who enroll on a phase 1 clinical trial for cancer care will have a measurable response to that. And less than 1% of them will go into complete remission with a phase 1. I've seen it one time. It was cool. So as a palliativist, though, I think a lot of people might think that I'd take a dim view of phase 1 trials, and the opposite is true, because we don't make progress in treating diseases if we're not trying new things, right? There is no other way that you go from a 4-year, 5-year overall survival to a greater than 95 5-year overall survival in 60 years. And that's been the case with the most common cancer we treat in children, acute lymphoblastic leukemia. How do we get there? Phase 1, phase 2, phase 3 clinical trials. And you don't get there any other way. And we're not going to get to the future any other way. So I am very supportive of enrollment. But more than that, though, we have to recognize that we are dealing with children who have limited time. And limited time is precious time. And enrollment on these trials requires time. More trips to the hospital, more evaluations, more pokes, more labs. It's a gift from them to us and to the future children. And I think that patient-reported outcomes provide us an opportunity to do better. Pam Hines, who was my research mentor, did this really cool study in 2005 where she asked children who had just enrolled on a phase 1 clinical trial why they did it. And to demonstrate why this is a gift, they gave us 3 reasons. The most frequently reported reason was they were doing it for their parents. The second most frequently reported reason was they were doing it for some other kid that was coming in the future. And the least frequent thing that they said to us was they were doing it for themselves. It's one of my favorite studies. And I think that what PRO data gives us is an opportunity, because right now when I talk to kids about enrolling on a phase 1 clinical trial, what I am really telling them is what the CTCAE grading has showed us. And it goes something like this. The doctors of people, usually an adult, who took this drug said that about 20% of the time it caused abdominal pain that limited their ability to do things during the day to a moderate degree, which I don't think is really helpful. Pro data gives us an opportunity to really provide better informed consent. Because what I am telling them is other children who took this drug told us that this is how it made them feel, which is a much different conversation. And finally, I think it goes beyond phase 1 or even phase 2 or phase 3. If we have pro data available, when I'm talking to a child about going on a palliative chemotherapy option, I can literally say to them, well, bud, listen, other kids who took this drug said that these were the side effects. And if you're telling me that you're really done with nausea and vomiting, well, 60% of the kids who took this said they had nausea and vomiting. Might not be a good option for you. Let's think about something else, right? I don't know, call me crazy. I think that's better. And I think PRO gives us an opportunity to do that. So what's the future? So all of the data I've showed you today, I hope has convinced you that kids are experiencing more symptoms than they're telling us about. And that is especially true with emotional symptoms. And they're only going to tell us if we ask. To me, it seems likely that we'll find some similar positive outcomes in children if we incorporate PRO data into clinical care. And I'm really excited about Epic because Epic does have the ability to incorporate PRO, where when a patient checks in, they can actually complete PROs, and then that can actually be reported in real time to the clinician taking care of them before they ever walk into the room. They can see PRO data. And so I'm sort of excited to see, I mean, obviously we've got to get it implemented first, right? But you can bet your bottom dollar I'm going to start talking about like, okay, can we incorporate PROs so that we can actually do this in a better way. The bottom line is that I feel like this is good care and that we owe it to our patients to use systems that work for them. And I think this is a system that works. The last thing I want to do is thank a lot of really important people. The first and foremost is my family. They put up with me endlessly talking about these things at dinner. I hope that it may have sparked some scientific curiosity in my children, but I'm not sure. And also a huge thank to my wife who, makes sure that I get to work on time and everything runs well and that everybody's happy and good. I want to thank my collaborators. Pam Hines has been my mentor since I was a fellow. She's one of the most wonderful people in the entire planet, and she has continued to provide mentorship to me even all these years later. I can still call her on the phone, and she helps me, which is amazing. Bryce Reeve, who is the psychometrician and genius behind all of this. And then Lee Lin, who is an amazing statistician who taught me a lot about how to detect asymmetry in a table. Amazing. I didn't know that. It's called a Bowker's test. Cool. I also need to thank the Children's Hospital Foundation. They funded our participation in this through the Jonathan M. Hoy Memorial Fund and the Palumbo Charitable Trust. They were the ones that funded our participation in this and helped us pay our subjects and also paid for Sharon's time. The Children's Hospital Foundation has been the most amazing organization in our ability to grow and expand palliative medicine here. We literally wouldn't be where we are today without them, and I'm so incredibly grateful to them. I also want to thank our PHO and PMSC clinical research staff. As I mentioned, Sharon DeBridge is one of the most amazing clinical research coordinators on the planet. No, you cannot have her. Doreen Samegi is an IRB and regulatory wizard and helped us. And then Susanna Taub is the awesome manager of that program and has always advocated for palliative oncology studies. And I really, really appreciate her. I also shout out to any resident or junior faculty in the room. I will note to you that I have less hair on the top of my head than I would like, and more of it is gray than I would like. And I still meet with my mentorship team. And those people are really important to me. Bob Arnold, Pam Hines, Javier Kane, Ross Hayes. Ross Hayes is the one who introduced me to palliative care. I wouldn't be here without Ross Hayes. Linda McAllister Lucas was really supportive of me in this. And now I have Dr. Dermody giving me guidance as well. And I really appreciate all of those people. And then last but not least, my palliative medicine and supportive care family. I need to shout out to Carol May and also to Amanda Brown. When Amanda came along, that relieved me a little bit of being on clinical service all the time. And Carol takes a lot of responsibility for the clinical service on a daily basis. If the two of them didn't exist, I wouldn't have had time to participate in this and learn all of these things and push this field forward. And so heartfelt thanks to the two of them and everybody else in our division. And with that, I will leave a little bit of time for questions here. I think I chose this picture. This is in Sequoias National Park. These are giant sequoia trees, which are amongst the largest living organisms on the planet. If you have not been to Sequoias National Park, I highly, highly recommend that you go. It is the most magical place I have ever been. And to give you some perspective, right here, if you squint, those are my two teenage children standing next to these gigantic trees to give you an idea of just how massive these things are. I think that we face a lot of really big problems in pediatrics, and sometimes they may seem insurmountable, but I think this picture demonstrates to me that there's beauty in the problems that we face because it pushes us to move things forward and to make things better. And so I hope that this is something that I've done that makes things a little bit better. And with that, I'll just take any questions that you guys might have.